Bismillahirrahmanirrahim. Today we will have case quiz number 66. Case data: 47 years old female working as nurse, complaining of 3 months history of dry eye and mouth and aching upper arm muscles and 3-day history of left-sided facial weakness. For the previous year, she had been suffering from fatigue, poor sleep, and non-specific joint pains. 6 months previously, she had developed pustular psoriatic rash on her palms and feet, which is resistant to topical treatments. There is no attendance history of infections, arthritis, colitis, or recent foreign travel. The patient had last visited her family in Nigeria 5 years previously, so the last travel to other country is 5 years ago. And she was married and have 2 kids aged 8 and 10 years. She had lived in the UK for the 5 years since the last visit from Nigeria. Examination: palmar pustular psoriasis, tender deltoid muscles, swollen parotid glands, left lower motor neuron facial nerve palsy. Joint examination was normal with full range of motion and no synovitis. Shermer test was positive. Investigations show normal fasting blood, full blood count, or CBC, normal liver and renal functions, CBK elevated, rheumatoid factor and anti-CCB negative, ANA by immunofluorescence negative, ANA profile all are negative, ANCA negative, HLA B27 negative, serum ACE normal, and chest X-ray clear. So, think for this case. So, what is the diagnosis? The answer here is, it is unusual presentation. The family history and the past history is important, and the full-blown picture of psoriasis, parotid inflammation, and so on and so on. So the answer is HIV, which is very underestimated, especially in Arab and Muslim countries. The answer is HIV, human immune deficiency virus infection. The musculoskeletal manifestations of HIV infection: multi-system inflammatory autoimmune conditions like SLE, primary Sjogren syndrome, and antisynthetase syndrome are important differential diagnosis for this particular case. However, her profession and travel from an HIV endemic area, Nigeria, means that HIV must be considered. HIV would account for chronic fatigue, late-onset aggressive palmar pustular psoriasis, myocitis, and parotid enlargement with facial nerve involvement, which is called diffuse infiltrative lymphocytosis syndrome, DILS syndrome. Some patients develop symptoms in association with seroconversion. Unexplained arthralgia may occur in 5% of HIV-positive patients who also suffer from fibromyalgia-like symptoms. Joint pain may occur in the absence of synovitis. A lower limb self-limiting non-erosive monoarthritis can occur. Psoriasis, myositis, and DILS syndrome can all be the initial presentations of HIV infection. Psoriasis may be dramatic and intractable with poor response to topical treatment, such as in this case. Myocitis is usually subacute and progressive. Skin involvement is rare. EMG studies can be normal or show non-specific short-duration polyphasic motor unit potentials with abnormal spontaneous activity. Muscle biopsy may show infiltrate of inflammatory cells in necrotic and non-necrotic fibers. Often the lesions are ill-defined. In HIV-positive patients, it is important to rule out opportunistic infections such as toxoplasmosis, which can occur during immune compromise and also present with muscle weakness and raised muscle enzymes. So, the muscle weakness here may be due to HIV infection itself or opportunistic infection secondary to the HIV. DILS syndrome occurs in 3 to 4% of HIV-positive patients. Proposed diagnosis criteria for DILC syndrome include HIV seropositivity with either bilateral salivary gland enlargement or xerostomia for more than 6 months. Histology show lymphocytic infiltration of salivary or lacrimal gland in the absence of granulomatous or neoplastic enlargement. Gadolinium 67 scintigraphy of salivary gland is positive. Inflammatory myopathy and DILS syndrome can be associated with infiltrative peripheral neuropathy, lymphocytic hepatitis, and lymphocytic infiltrative pneumonia. This woman's facial palsy may have been secondary to the parotid gland infiltration. Regarding the further investigations needed, a careful history of HIV risk factors include needle stick injury, either inside the UK or abroad, intravenous drug use with needle sharing, and sexual contact with persons at risk of HIV or from HIV endemic areas. The most important test is an HIV test. Combined antigen antibody tests currently used for screening will detect patients within 4 weeks of exposure. Patients need appropriate counseling and consent before testing. 50% of HIV-infected patients in the UK are ignorant for their diagnosis. CD4 count is helpful in tracking progress, but it is expensive and should not be used to confirm diagnosis. Assessment of other sexually transmitted diseases and infective hepatitis screening are also needed. This woman was HIV positive with a CD4 count of 200. Her potential risk factor was her husband, who traveled regularly to Africa on business, but he refused to do HIV testing. Regarding treatment of HIV is highly specialized and should be conducted under expert supervision. Current standard therapy is highly active antiretroviral therapy, which is called HAART treatment, HAART. Low to moderate dose steroid may be used to treat glandular swelling and interstitial pneumonia, but immunosuppressive therapies, including steroids, need to be used with caution as they may increase viral load and worsen the illness. Sick symptoms of the dry eye and the mouth are treated symptomatically. The facial palsy may not respond to treatment and may be permanent. Psoriasis associated with HIV is often resistant to topical treatment. Methotrexate and cyclosporin may improve skin lesion, but there is increased risk of systemic infection. Hydroxyurea is generally considered a safer alternative compared to methotrexate and cyclosporin. The psoriasis usually still with HIV treatment. Explosive reactive arthritis can occur, which is difficult to treat with conventional therapy. The association with HLA-B27 is less strong, particularly in African population where the HLA-B27 prevalence is already low. What about the implications on her family and occupation? The patient's immediate family, husband and children should be tested for HIV. If her children test negative, then their future risk of transmission from her is negligible. Her husband refused HIV testing. Whatever his HIV status, counseling about sex and contact tracing is important, and there is implication for future pregnancies, primarily around the time of delivery. Implications for her employment depend on her workplace. She is safe to work in all environments apart from an exposure-prone environment where she is unable to see her hand and may catch them on a spike of bone or surgical instrument, e.g. assisting some operations in theater. She should not work where there is high exposure to TB. She should have antibody testing for varicella and cytomegalovirus. We talk about the musculoskeletal complications of HIV infection. What about the possible musculoskeletal complications of HIV treatment itself? Complications of heart regimen include metabolic abnormalities with lipid abnormalities, insulin resistance, and the change in the body fat distribution. Although low BMD, osteopenia, and osteoporosis are frequent in HIV positive patients, it is still unclear whether this is a direct consequence of the viral infection or of the antiretroviral drugs. Treatment is with bisphosphonate plus calcium and vitamin D supplementation. The most important three complications of HIV treatment are zidovudine-induced myopathy, immune reconstitution, inflammatory syndrome, and osteoporosis. You can stop here the video and read the complications because I don't want to read all of this to save time. And thank you very much for your attendance, and we will meet you tomorrow with case quiz number 67. Wassalamu alaikum wa rahmatullahi wa barakatuh.